Welcome to Azin's Journal Club, episode 56. I am Dr. Z, here with KC, and today we're talking about a patient many of us dread on the wards, someone with a prior heart attack, an implantable defibrillator, and recurrent ventricular tachycardia. The trial is VANISH2, published in the New England Journal of Medicine in early 2025 after an online release late in 2024. KC, paint the picture of who this patient is.
So picture a patient who had a myocardial infarction years ago. They have scar tissue in the heart muscle, and that scar is the perfect substrate for ventricular tachycardia, a fast, dangerous rhythm coming from the ventricle. Because they are at risk of sudden death, they have an implantable cardioverter defibrillator, an ICD. The defibrillator does its job. It shocks them out of these rhythms or paces them out, so it prevents sudden death. But it does not stop the arrhythmia from happening in the first place.
And that is the crux of the suffering. The ICD is a safety net, not a cure. Every shock is painful, frightening, and associated with worse quality of life and even worse outcomes. So the real clinical question is how we suppress the ventricular tachycardia itself. KC, what are the two main tools?
Historically, the first move has been antiarrhythmic drugs, usually sotalol or amiodarone. Amiodarone is effective but carries a heavy long-term toxicity burden: thyroid, lung, liver, skin, eyes. The other tool is catheter ablation, where an electrophysiologist threads catheters into the heart and burns the scar-related circuits that generate the tachycardia. The traditional sequence has been drugs first, and you reserve ablation for when the drugs fail.
Right. And VANISH2 asked the sequencing question directly. Not ablation versus nothing, but ablation as a first-line strategy versus antiarrhythmic drugs as first-line in patients who had not yet failed drug therapy. That word first-line is the whole point of this trial.
Exactly. They randomized 416 patients, all with prior myocardial infarction, ischemic cardiomyopathy, an ICD, and ventricular tachycardia. About 203 went to catheter ablation as the initial strategy and 213 to antiarrhythmic drug therapy. The drug arm used a predefined scheme. Patients deemed appropriate for sotalol got sotalol, and those considered higher risk got amiodarone. Median follow-up was about 4.3 years, and the trial was funded by a Canadian public research agency, not industry.
And note the population, over 95% male, and exclusively ischemic cardiomyopathy. We will come back to why that matters. What was the primary outcome?
A composite of all-cause death or, after a 14-day treatment phase, a set of serious ventricular tachycardia events. VT storm, appropriate ICD shock, or treated sustained VT below the detection threshold of the device. The composite occurred in 50.7% of the ablation group versus 60.6% of the drug group. The hazard ratio was 0.75, with a confidence interval that just crossed below 1 and a p-value of 0.03. So a statistically significant benefit for first-line ablation.
A significant result on the composite. Now, same discipline as always. KC, what is the most important question to ask of a composite endpoint?
What is driving it? And here the answer is similar in spirit to a lot of these trials. It is not mortality. All-cause death was 22.2% in the ablation arm versus 25.4% in the drug arm, and that difference was not statistically significant. So ablation did not save lives over more than 4 years. The benefit came from the arrhythmia components of the composite.
So once again, no demonstrated mortality benefit. Let that anchor the interpretation. What specifically improved on the arrhythmia side?
The clearest signal was in treated sustained VT below the detection rate, which was 4.4% with ablation versus 16.4% with drugs. So ablation reduced the burden of these slower, treated VT episodes substantially. There were also favorable trends in VT storm and inappropriate shocks, contributing to the composite.
Now here is a subtlety I really want residents to catch, because it is where the trial gets clinically rich. The drug arm was not monolithic. There was a sotalol-eligible stratum and an amiodarone-eligible stratum, and the comparison played out differently in each.
Right. Among patients who were sotalol-eligible, meaning generally the lower-risk group, ablation looked clearly better than the drug, with a hazard ratio around 0.64. But among the amiodarone-eligible patients, the higher-risk group, ablation versus amiodarone was much closer, with a hazard ratio around 0.86 that was not significant. So a lot of the overall benefit came from ablation outperforming sotalol, not from ablation beating amiodarone.
And that reframes the takeaway. This is not ablation crushes all drugs. It is more like first-line ablation is a reasonable alternative to starting a drug, and it is particularly attractive when the realistic drug alternative is sotalol, or when you're specifically trying to avoid the long-term toxicity of amiodarone. If amiodarone is the comparator, the case is far less clear-cut.
And the amiodarone toxicity angle is part of the value proposition. Even if amiodarone suppresses VT comparably, you are signing the patient up for years of cumulative organ toxicity and monitoring. Avoiding that has real value, separate from the arrhythmia counts.
Well put. Now, let us be fair about the harms and limits of ablation itself. It is an invasive procedure.
There were procedural risks, the usual ones for VT ablation, vascular complications, and uncommon but serious events around the procedure. And the limitations are important. The population was over 95% male, so we have very little to say about women. It was exclusively ischemic, prior MI scar, so we cannot extrapolate to non-ischemic cardiomyopathy, where the substrate is different and ablation is generally harder. And these were experienced ablation centers, so results may not transfer to lower volume settings.
There is also the lineage to acknowledge. This builds on the original VANISH trial from 2016, which studied ablation specifically in patients whose VT had already broken through drug therapy and found a benefit for escalating to ablation. VANISH2 moves the question earlier to first line. So the body of evidence is increasingly supportive of ablation having a central role, but the precise sequencing is still being refined.
So how does this land for us as hospitalists, since we are not the ones doing the ablation?
A few practical lessons. First, when a prior MI patient with an ICD lands on your service with VT, recurrent shocks, or VT storm, this trial reinforces that early electrophysiology involvement matters. The old reflex of just loading amiodarone and moving on is not the only path. Ablation is now a legitimate first-line consideration, and the EP team should be in the conversation early.
Second, the amiodarone point is squarely in our wheelhouse. If we are reaching for amiodarone, we should be thinking about the long-term toxicity and whether this is a patient who might be better served by a referral for ablation instead, especially the lower-risk, sotalol-type patient.
And third, the honest framing. VANISH2 is a positive trial on its composite, but it did not show that ablation saves lives, and a good chunk of its benefit reflects ablation beating sotalol rather than amiodarone in an almost entirely male ischemic population. So we present first-line ablation as a strong option to discuss with the heart rhythm team, not as a universal mandate.
So on rounds, get EP involved early for the prior MI patient with VT, weigh ablation as a genuine first-line choice, and be especially mindful of it when the alternative is sotalol or when you are trying to spare someone amiodarone.
Exactly right. VANISH2 nudges ablation earlier in the treatment of scar-related VT, with a real reduction in arrhythmia burden, no proven mortality benefit, and a benefit that depends a lot on who the comparator drug is. Thanks, KC. We will see everyone next time on ASIN's Journal Club.